Welcome to today's Explainer. All right, doctors, grab your stethoscopes because we're diving into an intense, rapid-fire bedside rounding session. I'll be your attending today, and we're treating this like a high-stakes board exam review. We are going to master the pathophysiology, the murmurs, and the management of the four major valvular lesions. Let's get to work. Here is our patient census for morning rounds. Foundations of valvular lesions, bedside case, aortic stenosis, bedside case, aortic regurgitation, bedside case, mitral stenosis, bedside case, mitral regurgitation, and finally, murmur mastery and final review. Let's jump right in. Section 1. Foundations of valvular lesions. The logic of hemodynamics. Before we step into the first room, we really need to lay down some ground rules. Look, rote memorization is going to fail you on the boards, but logic never will. Every single valve fails in one of two ways. Think about the first mechanism, stenosis. The valve just won't open. This is purely a pressure overload problem. The chamber has to work so incredibly hard against a fixed obstruction that pressure builds upstream, and the muscle gets thick and hypertrophied. Now consider the second mechanism, regurgitation. The valve won't close. Blood is leaking backward with literally every single beat. This is a volume overload problem, so the chamber just stretches and dilates until it eventually fails. Basically, keep this simple analogy in mind. Stenosis is a blocked pipe. Regurgitation is a leaky valve. Now, when you're at the bedside listening for these murmurs, you absolutely need a rock-solid system. Remember your auscultation map. All patients take meds. That's aortic, pulmonic, tricuspid, and mitral. You move sequentially from the right upper sternal border all the way down to the apex. And, hey, don't forget to match the murmur to the cardiac cycle. Is blood crossing the valve in systole or diastole? You also need to keep your S1 through S4 timing sharp. S1 and S2 are your normal valve closures, right? But S3, that's that puffy, dilated, early diastolic sound you get with volume overload. And S4 is the late diastolic sound of an atrium desperately kicking against a stiff, hypertrophied ventricle. Section 2, Bedside Case, Aortic Stenosis, Room 1. All right, let's step into Room 1. We've got an elderly gentleman who's been having a really tough time with the stairs lately. Listen closely to the intern's presentation. He's a 74-year-old male with progressive exertional dyspnea, 6 months of exertional chest tightness, and 2 near syncopal episodes. Vitals show a BP of 118/92. Notice that narrow pulse pressure? That happens because of his severely limited forward stroke volume. On exam, he's got the classic triad, angina, syncope, dyspnea, along with this harsh crescendo-decrescendo, late-peaking systolic murmur at the right upper sternal border that shoots straight up to both of his carotids. Oh, and definitely don't miss his small, delayed carotid upstroke, your classic pulsus parvus tardis. Notice the incredibly dangerous combination here? We've got a late peaking murmur plus delayed carotid upstrokes. Rule of thumb, the later the murmur peaks, the worse the obstruction. I want you to treat this like a Socratic dialogue, doctor. Spot the lesion. What exactly are we dealing with? And what is our absolute next step? Spot on. This is severe symptomatic aortic stenosis, and here is the golden rule you need to permanently burn into your brain. No pill is ever going to cure a mechanical obstruction. Medical therapy won't alter this course at all. The mere presence of these symptoms is the trigger for an immediate valve replacement. Depending on his surgical risk profile, we're talking about a SAVR or a TAVI. And this timeline right here brilliantly illustrates exactly why we have to act so fast. I always challenge my residents on intervention timing because once those triad symptoms show up, a seriously grim countdown clock starts ticking. If we do nothing, survival drops to 5 years after angina starts, 3 years after syncope, and an absolutely miserable 2 years once heart failure hits. Do not wait on this. Section 3, Bedside Case, Aortic Regurgitation, Room 2. Let's step out and head down the hall to Room 2. Now, things are a bit different here. We need to shift our hemodynamic logic from a pressure problem to a volume problem. Here's the history. A 39-year-old tall male with mild exertional dyspnea and this uncomfortable awareness of a pounding heartbeat. He's got a known congenital bicuspid aortic valve. Check out his vitals. A massive, incredibly wide pulse pressure of 162/48. He has bounding pulses, and his head actually bobs with each heartbeat. That's de Masset's sign. On auscultation, we hear a soft, early diastolic decrescendo murmur at the left sternal border that gets significantly louder when he sits forward and completely exhales. Now, please don't let his mild symptoms fool you. On the boards, a huge stroke volume is being ejected and then leaking right back into his ventricle during diastole. So as you're attending, I'm putting you on the spot. What is the lesion, and are we sending him to the OR today? Okay, so this is chronic severe aortic regurgitation, driven by that bicuspid valve. His ventricle is silently stretching over time just to handle that massive backflow of blood. The key takeaway? You operate based on left ventricular size and ejection fraction, not just symptoms. If his EF drops to 55% or lower, or his LV and systolic dimension dilates past 50 millimeters, he needs a new valve. If you wait around until he's severely symptomatic, well, you've already lost the ventricle. Section 4, Bedside Case, Mitral Stenosis, Room 3. All right, as we step into Room 3, I really want you to pay close attention to the patient's background because here, etiology is absolutely everything. The picture is a 42-year-old female immigrant with a childhood history of rheumatic fever. She's coming in with progressive dyspnea, orthopnea, and one frankly terrifying episode of hemoptysis, literally coughing up blood. Her pulse is irregularly irregular. When we listen with the bell at the apex while she's lying in the left lateral decubitus position, we hear a loud S1, an opening snap shortly after S2, and a low-pitched mid-diastolic rumble with pre-systolic accentuation. She's also got a booming loud P2, which points straight to pulmonary hypertension. Let's think about the upstream cascade here. She has a narrowed valve blocking filling, which forces the left atrium to stretch out, and that's backing pressure right up into her lungs. So spot the lesion, doctor, and tell me exactly how you're going to stabilize her. What 2 immediate interventions does she need? Exactly right. This is classic rheumatic mitral stenosis. Because that stretched out left atrium triggered atrial fibrillation, she's lost her atrial kick and her filling time is severely compromised. She urgently needs rate control and warfarin. Seriously, remember this for your exams. Never use DOACs for rheumatic AFib. Once she's stabilized, she's going to need mechanical intervention. Ideally, a percutaneous balloon valvotomy if her anatomy allows for it. Section 5, Bedside Case, Mitral Regurgitation, Room 4. Okay, hustle to Room 4, doctors, because we've got a high-pressure acute emergency on our hands. Look at the monitors. 60-year-old male, day 4 post-inferior STEMI. He just developed sudden-onset severe dyspnea and acute respiratory distress. He's hypotensive, writing at 88/56, and his extremities are cool. Clear signs of cardiogenic shock. His lungs are full of diffuse crackles, meaning flash pulmonary edema. Listen to his chest. There's a brand new, blowing hollow systolic murmur at the apex, blasting straight into his left axilla, along with a highly audible, puffy S3 heart sound.
Think fast. What just happened inside this guy's heart to cause such a catastrophic collapse? I want you to contrast this with the chronic AR patient we saw in Room 2, who was walking around totally fine with massive volume overload. Why is this patient crashing right now?
This comes down to the absolutely critical difference between primary and secondary pathology. Notice the mechanism on the left. He suffered a postural medial papillary muscle rupture post-MI. This causes acute primary mitral regurgitation. The valve apparatus literally broke. Because it happened so acutely, his left atrium was totally unprepared. It wasn't dilated enough to handle that sudden massive volume, so all that pressure slammed right backward into his lungs, causing flash pulmonary edema. Now compare that to secondary MR on the right. That's where the valve itself is totally normal, but the ventricle breaks and dilates over time, tethering the leaflets. Bottom line, our patient in Room 4 is a surgical emergency. He needs immediate afterload reduction and an OR right now. Section 6, Murmur Mastery and Final Review. Putting it all together. Phenomenal work on the floor today, everyone. Let's head back to the conference room and crystallize all of this into a high-yield review. Here's your definitive murmur map cheat sheet. We've got our systolic murmurs, aortic stenosis and mitral regurgitation, and our diastolic murmurs, aortic regurgitation and mitral stenosis. Now, check out those maneuver clues on the far right. Notice how the hand grip maneuver, which increases systemic resistance or afterload, actually forces more blood backward? That makes regurgitation murmurs like MR and AR much, much louder. But, and this is key, it leaves a forward-flowing murmur like aortic stenosis completely unchanged. That is exactly how you differentiate them at the bedside. To close out today's explainer, I'm going to leave you with one final provocative thought to really test your hemodynamic logic. If the Valsalva maneuver dramatically decreases venous blood return to the heart, basically starving the heart of preload, what exactly do you predict happens to the volume and intensity of these murmurs? And more importantly, why? Ponder that one before your next shift. Thanks for joining me on Rounds today. Keep practicing that auscultation and never ever stop questioning the logic behind the hemodynamics.